Well, thank you, everybody, for joining us this evening. I'm Doreen Heinman. I'm the program manager at the Sashbear Foundation, and we're very pleased to have you with us for this evening's presentation. The Sashbear Foundation's mission is to lead a mental health reform by promoting awareness of the need for early prevention, recognition, timely intervention, and access to affordable treatment for individuals with borderline personality disorder or emotion dysregulation. One of our major activities is providing programming and education to family members so that they can better understand and support the loved ones in their families who are struggling. So I'm very pleased that this expert education series is part of what we are able to offer to you as family members. I'm joined this evening by Lynn Corey, the co-founder of the Sashbear Foundation, and by Barb and Kathleen, who are two of our stalwart volunteers helping us with all of the work that we do. And of course, by our presenters for this evening, Janna Hobbs and Michael Hollander. And I'll tell you just a little bit about them before we get started. Janna Hobbs is currently co-director of the Boston Child Study Center in Maine, where she provides expert supervision and training to their DBT program, as well as clinical consultation to both patients and families. She's a licensed independent clinical social worker in Maine and Massachusetts, and is trained in and has extensive experience in dialectical behavior therapy and in family work. She studied at the University of New Hampshire and Simmons College, and throughout her career, she's provided individual and family treatment in a range of settings, including inpatient and outpatient. As part of her illustrious career, she was a co-founder of McLean Hospital's 3 East Continuum, which was the first residential intensive DBT unit for suicidal and self-injuring adolescents. And then she went on to serve as program director and director of clinical services at 3 East Continuum. And in addition to all of these treatment and leadership roles that she has held, she also values training and developing new clinicians. And throughout her career, she has supervised many interns, postdocs, mental health workers, and her broad experience ranges with working with many different diagnoses, different treatments, and directing different levels of care. And all of this informs her assessment and treatment planning in her work today. And of course, she is joined by Dr. Michael Hollander, who together with Janna is co-director of the Boston Child Study Center in Maine. And in this role, he provides expert supervision and training to the DBT program and clinical consultation to patients and families. You may be thinking that this sounds familiar, and I understand that they probably work fairly closely together. Dr. Hollander is a nationally recognized expert on the causation and treatment of self-injury, and he lectures throughout the US and internationally, I believe, on the subject. And he has been treating adolescents and their families for over 40 years. He also is a co-founder of McLean's 3 East program. He's the author also of a book called Helping Teens Who Cut, Using DBT to End Self-Injury, which was an award-winning book and is now in its 2nd edition. He is also on the faculty of the McLean, Massachusetts General Hospital Child Psychiatry Fellowship Program as an assistant professor. He's a supervisor, or was a supervisor, in the Behavioral and Research Training Clinic at the University of Washington, and since 2004 has been a trainer for behavioral tech, which is, of course, the main accreditation body for dialectical behavior therapy. It is the training arm of the Linehan Institute. And he travels both nationally throughout the United States and internationally to train clinicians throughout the world in dialectical behavior therapy. And he has a commitment in his long career to training clinicians in evidence-based treatment and values his continued involvement in clinical care. And we are so appreciative to have both of you here with us today. With that, I will turn it over to you for your presentation. Maybe I should just mention also that you are prepared to take some questions at the end, and we will moderate those so people can put questions into the chat or the Q&A, and we'll get to as many of those as we can at the end of the presentation.
All right, we want to share our, we're going to share our slides here in a second. I should also say, while Janna's doing that, that Janna and I are married, so if we seem over familiar with one another,
that would be the reason.
That would be the reason. Well,
so
you go ahead.
First I want to say it really is an honor to be here, and are so appreciative of the work that Sashbear does. It's an organization that's very close to our hearts. And so we are honored to be here, and also want to thank people for coming. I'm assuming if you're here that you know of someone or care about someone who may be self-injuring, and we hope that what we have to tell you will be helpful to you. It is generally people who are self-injuring are suffering somewhat, and people who care about them share that suffering often. So we're glad you're here, and I am going to say as little as possible, since Michael's the one who usually presents. I'm here to support. He is actually the one who wrote the Helping Teens Who Cut, so he is the expert on self-injury. But I may chime in from time to time.
I hope so. I hope so.
Turning it over to you.
All right. So there are very few things, I think Janna highlighted it. There are very few things that are more worrisome to parents and more mystifying in some ways than self-injury. So tonight, what we want to do is tell you a little bit about the prevalence, how, just the statistics. Then we're going to review the reasons that people self-injure. And for family members, I think this is really going to be really key part to really hone in on. Sort of a spoiler alert goes something like this, is that most of the time what parents see as the problem, which is self-injury, the adolescent sees as a solution to a problem. And so if you have those very different perspectives, you can see right away that it can be a difficult behavior to understand and to navigate. But hopefully by the end of this, you'll have some understanding about why people self-injure, both the psychological reasons and some of the biological reasons about why it actually works and what it works for, and then where do families fit in and how to think about that. Okay, so let's talk about what non-suicidal self-injury is. Self-injury. So self-injury is the deliberate, intentional damage of skin tissue without the intention to die. Now, and very few people actually die from self-injury. It is always a worry, though, that someone in some frantic state could cut more than they intend. But that, again, that rarely happens, but it's an understandable worry. The general behaviors that we're speaking about are cutting, which is the most frequent way that people self-injure. But there's also burning, punching walls, some kinds of scratching, some kinds of skin picking, but not entirely. The most frequent way people self-injure is through cutting, but burning, breaking of bones, punching walls, scratching, or some kinds of skin picking. And when it comes to skin picking, there's a little bit of a discernment you have to make about what's driving it. Non-suicidal self-injury does not include other kinds of injurious behaviors, however. It doesn't include eating disordered behaviors, smoking, piercings, or tattoos for the most part. There are some exceptions, and
explain why that is.
Yeah, it doesn't include these because for the most part, the behaviors that I just outlined, the eating disordered behavior, smoking, piercings, or tattoos, are not done in the service of helping someone feel better, okay, in the short run. That is, I'm in an aversive psychological state and I self-injure, I immediately or pretty quickly feel better. It doesn't map on all that well to these other behaviors, but it's not to say that these behaviors in any way aren't worrisome or dangerous. So let's just spend a moment or two, and since you don't have the slides, I'm not going to go on too long about this, but let me just say that the statistics we have are kind of frightening about the prevalence of non-suicidal self-injury in the community and in the samples of outpatient and inpatient people, and that this actually has significantly worsened since the pandemic. Not a surprise, but it turns out that it's a fact. For example, non-suicidal self-injury in community samples changed from around 17 to 20% to 27%, which is an enormous leap. And when we spend a little time thinking about what adolescents were robbed by the pandemic, just developmentally, what course they should have been on, getting out of the house, socializing with friends, doing all the things that are part of adolescent development. The pandemic just threw a monkey wrench isn't strong enough to say what it actually did to our kids. So things have gotten worse. We have some sense about age of onset. Age of onset for non-suicidal self-injury, since I've been interested in it, has gotten younger and younger. When I first became interested in it, it was generally something that happened certainly in early adolescence, 13, 14. But now the age of onset can be around 11 years. I've also worked with and did a consultation on someone who began to self-injure when they were 9. So we don't know why the age is coming down. We can make a lot of speculation about social media, about any number of things, about this being a behavior that's more in the mainstream. There's lots of speculation, but the fact of the matter is that kids are harming themselves at significantly younger ages. And we're not sure, because it's not really been well studied, but there's some evidence that 40% of adolescents will stop self-injuring within 1 year, and that approximately 80% will stop by 5 years. But you can do, unfortunately, a fair amount of scarring to your body in that amount of time. We also know from some longer-term studies of adults that the high-action behaviors in say, a diagnosis like borderline personality disorder, those high-action behaviors, suicidal behaviors, self-injurious behaviors, will also drop out over time. People still are suffering, but they're not harming themselves. So we also know that about 75% of adolescents who engage in self-injury report that they've done it more than once. And those kids who have only done it once, we now have some evidence that they have other kinds of comorbid psychological and psychiatric conditions. So this is a behavior that people really need to keep their eyes on. It's also linked to completed suicides later in life. So somebody who's self-injuring is not necessarily imminently at risk for suicide, but you are much more likely to be in that pool if you have a history of self-injury. The reason for that, we think, is that self-injury is a kind of behavioral rehearsal of hurting yourself, and that once you cross that barrier, it will be easier to cross that barrier later in life. So again, it's a behavior that we really need to get on top of. All right. So still, although this is also changing, in clinic populations, girls are overrepresented, but however, in community samples, it's less of a gender difference. So boys are catching up, you can say. Okay. Okay, now most often, and I'm going to get into the reasons in a second, but most often self-injures harm themselves on their arms or their legs. Uh, Sometimes, inner thighs where people can't see it, but on shoulders. It's in some ways important to know a little bit more about the placement of the self-injury, because there's um, a correlation between people who cut themselves on their face or neck. These folks, you can begin to wonder whether there isn't something psychotic going on, or whether the person has some sort of a trauma in their lives. And that most self-injures, it used to be called, believe it or not, it used to be called delicate cutting, because it was so fine. And I'm sure some of you have seen your kids' marks about straight lines going across. I mean, it's carefully done. When it's not carefully done, when it's really attacking your body, that also correlates more with someone who unfortunately has had a significant trauma history, and probably has PTSD. But because someone is cutting on their face, that doesn't mean that. It's just something that clinicians and family members should keep in mind. All right, so why in the world would someone self-injure? And again, this is the part families that and family members that sometimes it's really hard to see. And so I think sometimes out of parents' worry, I mean, this is true for all of us, but when our emotions rise, our capacity to think openly and clearly starts to narrow a little bit. So if you find yourself, understandably, and who wouldn't be worried, and that you've got a theory about why your kid is doing what they're doing, all I'd ask is that you open up your mind and see whether what we're going to talk about next might make some sense. Of course, the other thing that happens when people's emotions rise is that they can't think at all. So sometimes people think too narrowly, and sometimes they think they can't think at all. All right, but the largest group of self-injures, this is what they tell us, and I have no doubt in my mind that it's true. I have no doubt in my mind that it's true because I've heard the same thing for 40 years from kids. I heard it the first time I heard about self-injury, and I heard it the last time I heard about when I asked about self-injury. So I think it's true. For the most part, non-suicidal self-injury is an emotion regulation strategy. That is, if you cut yourself and you're in a high state of emotional arousal, you will calm down very, very quickly. It absolutely works. And a little later on, we'll have a chance to talk a little bit about the science behind it. But what you have to know is that this is a behavior that generally calms people down. Now, that's the largest endorsed reason, okay? Now, it also can be, there's a group of kids who are on the numb and empty side of things. So we have kids who get emotionally dysregulated, their feelings are going off the roof, they self-injure, they immediately calm down, okay? Now, how long they calm down, that's another story, and we can talk about that. Sometimes they calm down for quite a while, and sometimes they only calm down for a short period of time. But then there is this group of young people and adults, but for us young people, who feel numb and empty most of the time. And this numb and empty feeling is really aversive. It does not, this is a psychological state, a state of being, which is really unpleasant. And when that becomes unbearable, if you reach for self-injury, you're going to feel the feeling that's going to come is that you're going to feel alive again. And oftentimes people who are upregulating their emotions, just as I said before, emotion dysregulation can be the kind of where it's jumping off the charts or it's down in the cellar. Two kinds of emotion dysregulation. But if you have the kind that it's down in the cellar, and that's when you self-injure, these are also the kids that sometimes, report that they need to see the blood. It's a feeling of coming alive again. So if you can imagine yourself feeling really dead on the inside, intolerable state of being, comparable to what it feels like when you're emotionally dysregulated the other way, when you're jumping out of your skin. There is this very simple behavior that you can do that's going to make you feel better. And it does. And we need to keep that in our minds. Let me just tell you that there are significant problems with this behavior. This really has to be ended. But in order to end it, it's best to understand it and the benefit it has. As crazy as that may sound, it is what it is. Now, there is also a group of kids who report that they self-injure as self-punishment. And I have no doubt that these are a group of kids. And I have no doubt that some of you parents out there are concerned that you have a kid like this, where the self-hatred, the self-loathing is off the chart. And these are kids who just feel at every turn that they are bad, they've done something wrong, that they're defective. They often feel because they've done something wrong that they really need to be punished. And so they reach. Now, if you imagine, put yourself in that state, you hate yourself. And it's not like, I kind of hate myself right now. It's bottom of the soul. I am a hateful, awful human being. Okay. You're not going to talk me out of the way I feel. This is reality. I may feel that what I deserve is some sort of self-punishment. Now, here's the thing that happens. I'm in an aversive emotional state. I cut myself, and guess what? I feel better. Now, I may tell myself that self-punishment really works, but is it the self-punishment really works, or is it the biology of what happens when people self-injure? But I don't want people to underestimate how awful and aversive these feelings are right before self-injury. Kids sometimes self-injure to communicate distress. So it sometimes, and some people sometimes think of this as attention seeking, but yeah, but rarely. It's more, I really want you to see, because for some reason I have not felt attended to, understood. And I really need you to see how distressed I am.
I don't have the words.
Or don't have the words, right? Or can't even, not only don't have the words to say I'm distressed, but don't have the words to say, this is the emotion that's distressing me, okay? And sometimes, it is kind of a thrill-seeking behavior and a distraction. You sometimes see this in early adolescence that may get in a group that's doing this, and then it becomes, the thrill of the day. But if that's the case, most often, if that is the primary reason that you're part of a group and it's thrill-seeking, like any other thrill, it dissipates over time, and those kids give it up. We got to go through this fast. So last thing I'm gonna say, and then Janna's gonna tell you something about radical acceptance and how to take care of yourself and what we can do. And I'll chime in on this. But one of the theories that we have about why self-injury works is that at the time of tissue damage, there are endorphins that are released into the bloodstream that are opioid-like endorphins, so that you're actually dosing yourself with some opioids. And then, and we know that's true. And then there's another theory which has been around for 100 years called pain offset theory. You can look both of these up by the internet, on the internet. Barbara Stanley for the endorphins, and Franklin is his first name. Could be his last name too.
Pain offset.
Pain
theory.
offset theory. This old man has lost it. Pain offset theory, which follows. It turns out that the old joke: you're walking down the street, you see your friend banging his head against the wall, and you say, "Why are you banging your head against the wall?" And he says, "Because it feels so good when I stop." It actually turns out that if you self-injure, after you self-injure, you'll be calmer, much calmer than you were right before you self-injured. So there's a kind of a straight biology theory, and then there's this pain offset theory. So Jane, tell them about radical. What are these parents supposed to do?
Yeah. Not just one thing, for sure. So probably the biggest challenge and for any parent or caretaker is it sort of goes against everything in your body to have your child harming themselves. And so I think it's hard for parents to think clearly about this. And one thing we know is that trying to remove everything from the house that they could self-injure with won't stop it. Setting limits won't stop it. Trying to talk them out of it generally doesn't stop it. The hard part here is that this is your child's problem to solve, and there are things that you can do to support that and scaffold that, and there are things that you can do that actually get in the way. One of them being, if you only take the side that says you have to stop this, this is unhealthy, this is not okay, that sort of frees them up to take the other side and hold on tighter to the fact, well, but this works for me and nothing else works as fast. So I think the first thing you need to do is radical acceptance. So this is a DBT skill that is really challenging to do, but is a very, very powerful skill for any kind of extreme distress. And it really is basically coming to terms with what is. It is accepting reality and not trying to reject it. Because when you reject reality, whether that's, I can't deal with this, this has to stop, or any number of things that we do to try to move away from painful realities, you're increasing your suffering, right? Because we all have pain in life, and what we need to do is figure out how to tolerate it and how to deal with it. Trying to stop it or deny it, suppress it, generally, you in your heart of hearts that it's still there. So you're between a rock and a hard place. The hard place being the whatever is causing you pain in this situation, a loved one self-injuring. So acceptance is not approval. It is not resignation. Acceptance is simply saying, this is what is before me, this is the reality, this is what is happening. If you can do that, you will probably notice that you might get more sad, because when we're fighting a painful reality, generally we feel anxious and angry. When we accept it, we can feel some sadness, but then you're actually freed up to do some better problem solving and to think more clearly. Radical acceptance is not just, okay, yes, I know this is the problem that I have before me. It is body, mind, and soul, that you open yourself to what is. And there are some DBT skills that are helpful for this. This radical acceptance is a part of distress tolerance, and there are lots of good skills in there, just to put a plug in for DBT. Really helpful skills for human beings, not just people in treatment. So we would encourage you to look at them. But
Can I say something here?
absolutely.
Okay, so as John has explained, radical acceptance, you should also know that radical acceptance dissolves pretty quickly. And so just saying, well, I radically accepted it, and then of course it's going to come back, and then you can say, well, radical acceptance didn't work. But the way radical acceptance works is you have to keep radically accepting reality time and time again. And I think the harder the problem, the harder it is to radically accept things and your kid's self-injury. But again, it's not saying this is okay. It's saying this is what is. This is what's before me. Now, what am I gonna do?
So people have more questions about radical acceptance. It's what I think one of our favorite skills, because it allows you to think more clearly, and it helps you stay calm, actually, because you're actually dealing with you can see the problem more clearly. So we'd also like you to get support, whether that's a trusted friend, church, your parenting partner. Nobody should go through this alone. Please find places where you can actually talk freely. Don't stop activities that nourish you. You know, we've often worked with parents who don't leave the house, too afraid to leave their child alone when they're self-injuring. This is a delusion that actually that you can stop this. It's because it is your child's problem to solve. It is better for you to take good care of yourself, and so that you are available to your child in a way that's helpful. When you are educating yourself, plug for Michael's book because I think it's a good one. But there's a lot on the internet that's probably not trustworthy. And so, you know, qualified professionals and other trusted resources, Sashbear being one of them, NEABPD, places like that. McLean Hospital has some great webinars as well. But don't just Google it, because it may not be accurate information. And then, so going back to your role in terms of not trying to change your child's behavior yourself, we really encourage people to learn how to validate. This is probably radical acceptance and validation are the two most important skills for parents when we're teaching DBT. But generally speaking, people who self-injure feel their feelings deeply, and they're big super sensors, and they sometimes feel out of sync with the rest of the world that maybe doesn't feel things as deeply, and they really benefit from being validated. And by validation, it means really just recognizing their experience, and not moving to problem solving really quickly. We could say a lot more about validation, but I don't, if we have time, we can circle back to that.
Yeah, we're going to talk about what
you're talking about, issues around confidentiality.
Yeah.
So Go ahead.
Okay, so, one of the things that we want parents to be is intelligent consumers of mental health. So, I'll take the first. So the first thing when you're speaking with the clinician is to understand what the treatment is, how it's going to work, and where things are on confidentiality. I think that parents should not have the expectation that the therapist is going to tell them every time the kid self-injures, because if my therapist told my parents every time I self-injured, I'd probably stop telling him that I was self-injuring. So we want to keep that relationship free and clear. That doesn't mean that you have to be in the dark, because I think that it is also fair to say when can we know something about this. And I think it's for therapists to say, in 12, 14 weeks after I get to know your kid a little bit, we can have another meeting and I can tell you where we are on self-injury. You want to say something about confidentiality? No.
You're talking about the
Well, I was going to say a couple of things. Find out what your kid's therapist rule is about confidentiality. Also, Janna mentioned this earlier, and I think I would have said it a little bit differently. If your current therapist is encouraging you to take all the sharps out of the house, then take all the sharps out of the house. However, fact of the matter is that if you probably look around the room that you're in now, there are probably 15 things that you could find that could be used for self-injury. So that's a problem.
It's also, one of the things that in therapy, we're trying to help kids solve this problem themselves. And if it becomes their environment's responsibility, whether it's their parents or someone else's, if it's polarized in that way, that can leave the kid sort of saying, well, you're gonna take that side of it, I'm gonna take the other side, and I'm going to, and look, I can get around you, because they often can. I mean, kids can self-injure with pebbles. So that's what I was saying about trying to sanitize the environment. What instead you really want to be working with the adolescent around taking better care of themselves, about solving this problem. Mostly we're wanting them to learn how to manage their emotion dysregulation in ways that don't include self-injury.
Yeah, the biggest problem in some ways without self-injury is that it's a short-term solution to a long-term problem. So I may make myself feel better in this moment because something tipped me over and I'm really terribly dysregulated and my feelings are hurt, and I self-injure and then I feel better. But the problem is, just because of human nature, we rarely go back and say, well, I wonder what I could have done differently in that situation so that I wouldn't have gotten my feelings hurt, or I could have managed my feelings a little bit differently. Once the emotional problem is solved, we just move on. And this is just the way human beings have been constructed. So it's not so much a parental role, but it is incumbent upon the therapist to have a reason about why somebody should stop self-injuring. And so I would also want to hear, why the therapist that you're going to work with thinks the kid should stop injuring. I can tell you what doesn't work with adolescents, because I've tried many of them. Telling them that it's unhealthy, it probably isn't going to go anywhere. Telling them that they'll have scars and that people may not like the scars doesn't go anywhere. So there really needs to be more of a reason that they can buy into, that's going to help them relieve their significant suffering. And that's you're just making yourself feel better in the moment, but you're going to get whacked again emotionally, down the line. Can't we find some ways to help you become more skillful and resilient in these emotional situations? What else do we want to say? Want to say more about validation? We should. Oh, okay. So a couple of other things. Siblings. People are always saying, what do we tell the siblings? Well, first, you've got to include the teenager who's self-injuring at least in the decision somehow, so that it isn't that their private information is being spilled out to other family members. And of course, you have to keep the age of the siblings in mind. That is, what is it that they can what is it they can understand? So, for example, you might be telling a 14-year-old about their 16-year-old self-injury in a way that's markedly different than what you might say to a 9-year-old. So figure out what your kid can tolerate. It should be done matter-of-factly. It should be done, and the younger the kid it is, more matter-of-factly, and with some reassurance that their brother or sister is getting some help. In terms of extended family members, I always say that's on a need-to-know basis. If you have a family member that you think if they find out they're going to be less helpful, which usually means they're going to tell you all the reasons why your parenting was screwed up, maybe that person doesn't need to know. But if there's somebody in the family who you really can rely on and you feel will be a comfort, absolutely reach out to them. And we got it done. So we're open to questions.
There was lots of things coming up in the chat that
There were lots of things coming up in the chat. I'll start, and if there are questions there that are jumping out at you that you want to address, please feel free. But I know a question that's come up a couple of times already is whether there's any evidence that it becomes addictive. Is this an addictive behavior that really fits that same description?
it can be.
I think it's overdiagnosed that way. But because you are sort of, dosing yourself and feeling better after feeling lousy, it becomes terribly reinforced and can follow an addiction model. Sometimes it follows this way in that, one of the ways that you might know that it's addicted is that the child has to make more cuts in the same episode of self-injury, so that one cut, which was one dose, isn't going to be enough, and so they keep having to increase the amount of self-injury. That's one way.
Or sometimes go deeper.
Sometimes go deeper, but the treatment is still the same.
Great, thank you. Another question that's coming up regularly here is, what do you do if you're trying to get help for your adolescent or someone who's injuring themselves and they don't want to accept help? They're not interested, telling you it won't work, it won't be helpful. How do you manage that environment where they're really resisting treatment?
Well, that's a hard one, because you can say, could you just get a consultation for me just to see what it's like? But people don't do all, unless there's some buy-in for why you need therapy, it really doesn't work. And I've come to the conclusion that, as much as I hate to see people suffering, especially when we think we can be helpful to them, in some ways, until they come to it, it's at best we're going to do is a holding pattern.
Sometimes it can be a harm reduction to have, if the kid is willing to go and make a relationship with a therapist. But I think part of the question is, what is the barrier? Why is the child resisting? Is it because they've tried therapy before and it didn't work and they've lost hope? Or is it because they feel shame about the behavior? Is it because the thought of going to therapy, if they've never been, is scary? Based on the individual. So you might want to consider your particular child and what you know, and then try to continue the conversation. Just don't give up. Say, this is really something that I worry a lot about, and I'd like to keep talking with you about it, and really validate whatever you can, when you can identify more what the barrier might be, to validate, and also, we always say validate and ask for change. So it's, and sometimes that can take some time. So go back to continuing to take care of yourself, and don't give up, keep trying.
Okay, I want to pick up on a word you said there, Janna, which is shame. And when somebody starts to feel shame around these activities, and that came up in the questions too, about, someone, really blaming themselves after they've done this. How do you respond as a family member? You're responding to both the emotion that's leading them to self-injure and having this conversation about the other piece that's then coming out of it.
Yeah. I think you have to acknowledge that the shame actually is the right emotion to show up. It may be more shame, they may have more shame than the situation requires. So can we just, does the intensity of this emotion fit the facts? And then that this is a behavior that's double-edged. We know it works for you, and we know it's holding you back. So, we hope you be able to sort this out, and we'll give you whatever help we can.
Generally speaking, I want to clarify for the audience, again, that you are really suggesting that families be actively involved in having conversations with their youth around this. This is not a situation where we want to simply turn away, ignore it, hope it's going to go away. We're really actively involved, but we want to be actively involved in effective ways. Is that correct?
Yes.
Absolutely correct. Sort of bugging your kid about self-injury isn't going to work. You have to, these discussions need to be timed right. That is not when the person is emotionally dysregulated or full of, or necessarily so full of shame they can't think, but in moments of more quiet, to raise it, and also to raise it mostly about how it makes you feel, knowing that this is going on. Now they'll tell you that, look, you're trying to guilt trip me, and you can just smile and say, that's about the last thing in my mind that this is about. This is about how worried I am that you're so distressed that you're reaching for this kind of behavior.
Yeah, I hope I wasn't misleading in talking about it being the adolescent's problem to solve. Mostly, I think I work with a lot of parents who are so focused on solving the problem for their child that they remove agency from the child, which doesn't work. So not in any way saying that this isn't it is a family problem, and you do need to recognize your child's sovereignty, and that and you have there are limitations to what you can make happen. You have to figure out how to be effective with your child, because the locus of control is with them. And so that was what I was meaning to say. But yeah, continue the conversations. If something fails, try a different tactic. Just don't give up. Yeah.
Great, thank you. And you've said as part of these conversations that we're having with our kids, we keep coming back to this idea of validation. And a lot of people are asking, how do I validate without actually sort of condoning the behavior? Can you give us some examples of that?
Yeah, well, let's just mostly what we're validating is the emotional distress, not the solution to emotional distress. So you don't have to say, yeah, it makes perfect sense. Anybody would cut themselves who was feeling the way that you were feeling. You can say things like, it was so clear how troubled you were, however you speak in your family about, and how hurt you were by this incident. And I don't think self-injury is the solution.
It's, we're always saying substitute and for but, because generally when you say, oh, boy, you were really up against it, that must have been really hard, but you really can't self-injure. It sort of wipes out the understanding and the child being seen and heard of the first part.
Right.
So put a period at the end of the sentence and then say something about how you hope that they can find some other way of managing their distress, or say and, but don't say but.
And I'd also suggest there are resources for learning how to validate. I was not someone who was really strong on validation, but I learned how to do it. I'm so glad I did. But my suggestion to parents is, if you're going to learn how to validate, don't start by validating your self-injurious team. Validate everybody else in your life, at work and whatnot. Get a hang of it, and so that you feel comfortable. Because oftentimes with these really sensitive kids, you validate and they say, there you go, sounding like a shrink. Is that what your shrink is telling you to do? Well, it's not going to work with me. Now, if that happens, you can simply say, yes, you're right. Don't deny it. If it's true, you're right. And what would have been a more validating way of saying what I said? So, it's, your kid isn't going to say thank you very much for being so as validating as you are.
But really, the key point for validation is that you are validating the emotion, not the behavior.
Right. And well, I mean, you don't have to validate what's not valid. Also, but that's a little trickier and goes, I think, beyond the few minutes we have. But yeah, I mean, really, the take-home message is for us is, what are the reasons? Knowing that this is a solution to a problem, that is what we see as a problem, most likely your kid sees as a solution to a problem. Radical acceptance and taking care of yourself during this, for parents during this really tough time. You are going to need to build your resilience and keep it up. This is something that could take months to resolve, and stay away from trying to solve this problem, and validate the emotions, and see if you can't get your kid into a good treatment.
So what would you describe as being a good treatment? You've spoken a lot about dialectical behavior therapy, and certainly there's all those distress tolerance skills that would be really effective. Is that sort of really the gold standard treatment for this type of issue? Is there something else that we could be looking for when we're looking for a therapist?
The facts of the matter is that there are probably 7 evidence-based treatments for people who are self-injuring. They all get the same results, but the most research has been done on DBT. So, we have a pretty solid foundation. Mentalization-based treatment has a curriculum that works with adolescents. General psychiatric management, which came out of McLean Hospital, also has a a way of working with adolescents, as does this treatment that comes out of Cornell Westchester, transference focused therapy. So I think the one that's most, and then not even, I would say wildly, but the DBT, I think, is still out there as the treatment you can most easily access of these treatments. But I would also say that if you're going to see someone who says they do DBT, that there are some questions you should ask about: are they on a consultation team? Who trained them? Are they certified by the Lenahan Institute? Things like that, because sometimes people say they do DBT and they actually don't do DBT.
Great. Thank you. Another question that's coming up quite regularly is family members who are really afraid to sort of have the normal kinds of disciplinary interactions with their kids, right? Like, oh no, you need to do your chores before you go out with your friends, those kind of things, because their kids escalate so quickly, or, the parent is afraid that the child will self-harm, or maybe the child is threatening that they will self-harm. How do we respond in situations like that to sort of maintain those normal household expectations and not, create problems further?
That's a hard question to answer without the specifics, because it could run from being really, really validating to sorry that you don't want to do your chores, but if you're thinking of but I don't think this is a reason to slice yourself up because you don't want to do the dishes. So it can be what you need to be careful about is that parents aren't being reinforced into parenting dysfunctional behavior by not holding reasonable expectations. Now, if your kid is in the middle of a crisis, that's a little bit maybe a little bit different. But I think when parents start bending the rules and the expectations, it rarely works out. So I would still, you may have to temporarily stop some things, but I would be really mindful about trying to keep things running in the family as normal as possible, even if you get pushback.
Yeah, this is tricky, and this is where getting some, parent guidance can really help, because you're managing so much, and if you let go of limit setting and having expectations, part of the problem with that is that can send a message to the child that you don't think they're capable, and so this is really, you do need to look at each individual situation, but it is one of the things that parents sometimes let go of: rules, expectations, and that can be a very slippery slope, with the child essentially feeling more hopeless about, that they can't do what might be age appropriate. So I think getting some consultation on that is usually helpful. Don't let go of limits, because that's also a way that kids feel, okay, yeah, my parents do know what they're doing. They can hold me accountable. I can learn to be accountable. And that's important, that everything doesn't fall by the wayside.
Yeah, and the other problem that I've seen happen time and time again is that there's no exit strategy for letting go of, how do you reintroduce doing the dishes? Well, I think you're well enough now to do the dishes. I mean, so unless you have a clear exit strategy, I would benignly and compassionately, as best you can, hold as many limits around normal family functioning as possible.
a couple people have mentioned self-harm that doesn't really fall into this category of self, like the cutting and burning type of things. And specifically, they've mentioned people who bang their heads against the wall to the point of blacking out or causing brain injury. How does a family member respond to this?
Yeah, that kind of head banging, I would want to get a really good diagnostic understanding. Is this some sort of developmental delay? Is this the beginning of some sort of psychotic episode?
Hitting one's head is a very powerful, it releases a lot of endorphins. So it is something that kids can stumble upon and use. But yeah, I would say get neuropsych testing, get a good evaluation if that's a behavior that is escalating.
And there are some behaviors that if you can't find a way in the family to work out, it may have to be that there may need to be some short-term residential where you're sort of people have more eyes on and are able to address this problem without invoking the usual family dynamics kind of thing. But that is a very worrisome behavior.
Okay, thank you. And one other thing that's come up a few times is around this idea of harm reduction. In other words, telling kids, okay, well, I understand that you have to self-harm, so let's just make sure you do it safely. Well, is that ever a good idea? Is that ever appropriate?
When we as soon as you go to ever, I have to say, well, I can't, it could be, and, I've got an imagination. I have never seen it work. So I've seen people who have attempted to use, elastic bands, doing other kinds of things, but usually it doesn't work. And no, I wouldn't say, it's like you say to your kid over dinner, I'd rather you drink at home than you drink outside of the home. So have a beer, with the notion that that's going to stop them from drinking out of the house. I just don't think it works. To the degree that someone doesn't have the skill set to manage their emotions, I don't saying, look, just do it less is not gonna work.
You want to hold the expectation and the belief in them that they can figure out other ways to tolerate their experience. And so yeah, I think again, there may be situations where that would be the case, but generally speaking, I think you would not want to say, I understand you need to do this. It's more, I understand you feel you need to do this, and there are other things you can do, and we will get you the help you need.
Great, thank you. That's a lovely, a fine distinction, but very, very helpful, I think, to understand that distinction in terms of validating the emotion that the person's experiencing rather than validating the behavior and the action they're taking. Is that right?
Correct.
Okay. Wonderful. Thank you. Thank you so much. For our audience out there, I'm sorry we could not get to all of your questions because there are literally dozens and dozens of questions still sitting here in the Q&A. I don't know, Janna, Michael, is there anything that you would like to add? Any last notes that you would like to say, or any questions that you've seen kind of fly past that you think should be addressed or you'd like to address?
I think we should come back and
answer questions,
do a deeper dive.
Yeah, and maybe do something where we're just going to take questions and about this.
I hope you both realize that we will take you at your word. You've said that you want to come back, and so we will work very hard on trying to get you to come back and answer more questions, because obviously there is absolutely an appetite and a need for family members to learn more about this topic. And we're just so honored that you were able to spend this time with us this evening. I want to thank you again for having done this. I know you've helped literally hundreds of families already just this evening out there. So thank you very much.
Thanks for having us.
Thank you.
Great. Thank you, everybody. Good night.